Hello, this is my group's case study called Shooting Up. The client we were presented with is John. John is 30 years old and currently resides in Philadelphia. He has been married for 9 years and has 2 daughters the ages of 8 and 5. For the last 7 years, John has been working as a heating, ventilation, air conditioning mechanic in a large hospital. He is overall a good employee. However, he has been losing credibility for his work performance due to personal issues. John, unfortunately, has been struggling with drug addiction. Due to that, it has interfered with his work, and the quality of his work performance has steadily been declining. Within his 3rd year at his job, it was noticed that John had been slacking off, missing work, and/or not completing his job. This has led John to be at a very low point in his life and is in need of professional help.
Why has our client come in? He is experiencing a lot of distress right now due to his substance use disorder. He is currently fearing losing his job, which is why he has come in right now. He's been very angry. He's been withdrawn from his family and goes a long time without even going home some days. He is frequently distressed due to the dependency on his heroin use. In particular, he's having to shoot up 3 to 4 times a day or more, and sometimes having to leave work early or not show up at all. And he said that he has nowhere left to turn. He's feeling really desperate right now. He is dysfunctional. His performance at work has been really poor. Like I said, he's not showing up sometimes, or he's having to leave early or disappearing. He's been in trouble several times, including the most recent suspension. His family life and his relationships are severely suffering. He's unable to take care of himself very well and unable to really be there for his family, for his 2 children and his wife. And then he is also using deviant behavior. His substance abuse is pretty extensive. He is using heroin every single day, multiple times a day, and sometimes other drugs as well. He is also dealing drugs to make money, and he is exhibiting a lot of risk-taking behaviors. And then him and his wife have also had pretty bad fights with a lot of yelling and threatening and gaslighting, and many of them have turned violent. And then into danger, his substance abuse comes with a lot of risks, including, overdose, which is probably the biggest one. And then he's also using polydrugs sometimes. We know the synergistic effects can be very powerful, which can also lead to overdose quicker than you would think. And in his case, he's using heroin with stimulants, but only on occasion. Other times, he's using heroin with alcohol or marijuana. He is also at risk from needle sharing when he goes to the galleries with other addicts. And then he also has a firearm, which he has left around his house occasionally within reach of his children. So it's a pretty big danger.
Over the last few years, John's performance has gradually deteriorated. Starting in his 3rd year at the hospital, John began arriving late for work and leaving early, first only once or twice a month, but then once or twice a week. Verbal reminders were set in place. Eventually, John's supervisor filed for a written reprimand. At this point, John asked to work the night shift, and his supervisor agreed. For a while, John's punctuality improved somewhat, but gradually deteriorated until he was rarely on time. Then John began to miss work altogether. Finally, his supervisor became exasperated and began the formal 3-step dismissal proceedings required by the union. John seemed rattled at this, and for the next 2 or 3 days, he did as expected. But soon his tardiness and call-offs led to termination. John consulted Desmond, the coordinator of his union employee assistance program. Desmond had seen these signs before with other employees and admitted John to an invasive addiction treatment program where he will remain in the hospital for a week, then follow-ups from home every day. John was taken aback, but he went to the program for an evaluation and was admitted the following Monday compliantly due to his severe drug use.
So John started to use drugs and alcohol around 11 years old. he as he got older, he progressed into more potent alcohol and cannabis use, and then he switched to hard drugs such as barbiturates and opioids. So yeah, he had an alcoholic father, didn't really care about his brother. Him and his brother often hit his mother and the kids. Um, Mother never had drugs, did drugs. She was kind of surprised when she learned her children were taking drugs, but never really did anything about it. And John never attended therapy as a child, and he briefly stopped taking drugs when his brother went to jail, but started back up after that.
The diagnosis that was decided for John is opioid use disorder, alcohol use disorder, and addictive disorder. Why we believe this is the diagnosis for John is because he's taking larger doses more consistently due to his tolerance building up. He has a persistent desire for opioids, unsuccessful efforts to cut down and or control opioid use. He spends a great deal of time obtaining, using, and recovering from the opioid's effects, and continued opioid use despite ongoing problems his addiction is creating. The symptoms that he's experiencing is decreased work ethic, increased anger, increased drug usage, withdrawing from his family, withdrawal syndrome, and dependency on opioids and alcohol.
The justifications for the diagnosis are he is experiencing patterns of substance use that are causing serious impairment and distress in his life. He's, experiencing all of the 4Ds. His life is completely wrapped up in his substance use. And then he's also, as a result of that, spending a majority of his time buying, selling, and using drugs. He's having to spend a lot of time doing that, and then also a lot of time trying to recover in between, even just to get to work some days, which is why he's missing so much work. And because of that, he's not following through with his obligations to his family or to work. It's a direct result of his substance use. He has continued to use heroin and other drugs despite the major impact on all of his relationships between his wife, between his coworkers, his boss, and then again continuing substance use in risky situations as well, despite knowing the danger in his words, in his more sober moments, he recognizes the danger that he's putting himself in, and yet he keeps doing it. And he is also experiencing tolerance, dependence, and withdrawal. And he, for a while, was using 3 to 4 times a week, not to get high, but just to even keep the withdrawal symptoms away. So that's the justification for our diagnosis. Considered but ruled out with stimulant use disorder, he occasionally uses cocaine or amphetamines and is mixing those with heroin to create speedballs, but he's not doing that very often. He said that he doesn't like the edge stimulants put on his high. And then cannabis use disorder was the other one we considered. He has significantly decreased his use after high school. The increased euphoria and calming effect of heroin replaced his marijuana use. And then there's no current indication of enough usage or enough of the symptoms to meet the criteria for a diagnosis.
Behavioral scientists generally regard drug addiction as a behavioral disorder that results when drug reinforcers assume control over a substantial portion of an individual's behavior repertoire. As such, addiction to drugs can be considered a form of excessive behavior occurring when other activities are expected and appropriate. Overeating and excessive gambling are other examples of inappropriate and excessive behaviors often attributed to an addiction of some kind but do not involve drug administration. A characteristic of each is that the initial exposure to a reinforcing stimulus, for example, euphoria, food, and money is followed by a progressive escalation in the behavior that produced it. Behavior that results in the availability of these reinforcers may eventually dominate the behavioral repertoire simply because the stimuli function has more potent reinforcers than other available in the individual's environment. This may be due to genetic predisposition or more likely to particular learning histories combined with relatively easy access to these reinforcers. For example, a high rate of reinforcement and insufficient contact with alternative sources of reinforcement.
All right, looking at the why and the how behind John's substance abuse, how he's learned this and what is keeping his substance use going. We're looking at the behavioral perspective, and early in his history, this substance use behavior was modeled by his father, who was prone to binge drinking episodes where he was also abusive to both his wife and his children. And then, as well as his peers, all throughout school, used substances all around him, and it was super easy for him uh, to get a hold of these substances and to enjoy them with his peers who were also using them. So this is all behavior that he's seen around him from a very young age and learning to do. And then some of the people in his life have enabled this behavior, particularly his mom, who remains passive and quiet about all of her son's drug use, and as well as giving him money. Even currently, every time that he's asked for it and been in need, knowing that he's using substances but still helping him. And then the other thing is operant conditioning. There's behavior reinforcement. So applying this to John's case, he's got the social reinforcement, which are also positive reinforcements. He's getting encouragement and approval from peers throughout school, and then with his new job, his coworkers, constantly, at first, were constantly inviting him out to the bar and really encouraging and just having a good time out. So he's getting that social connection that's reinforcing his behavior, and it just gets worse from there. There's also positive reinforcements, which are rewarding stimuli. So this increases his behaviors, such as, when he is selling drugs, he's rewarded with money to get more substances for himself. When he's using drugs, he's rewarded with the high from the feeling, and then also negative reinforcements, which is removing the aversive stimuli. So if we look at his withdrawal symptoms, he's using heroin frequently to reduce the symptoms of withdrawal.
So John has throughout his life had social experiences that have gone with drugs, starting in middle school with alcohol and cannabis. Correlating a good time with friends and drugs is an example of classical conditioning because they are experienced together at the same time. Even later, when he's holding down a job, he only starts using more because his friends invited him to drink with them at the bar. With the shooting galleries, there was 10 or more people together sharing an experience. Seems to me that socializing is correlated with drug use for John. With operant conditioning, John continued his drug use because of the increasing high he felt with increasing dosage and mixing drugs in high school. Later on, John was drawn to the shooting galleries due to classical conditioning and socializing, and stayed due to operant conditioning. His reward for staying was a supportive environment that he wasn't getting elsewhere, and an increasing high from more extreme heroin use.
Types of behavioral treatment options are aversion therapy and contingency management. Aversion therapy is a form of behavioral therapy in which an adverse, causing a strong dislike or disgust stimulus is paired with an undesirable behavior. This is in order to reduce and/or eliminate that behavior. This treatment primarily focuses on changing the behavioral aspect of addiction to encourage change in the habits present. Contingency management refers to a type of behavioral therapy in which individuals are reinforced and/or rewarded for evidence of positive behavioral changes. Interventions are based on principles of basic behavioral analysis. A behavior that is reinforced in temporal proximity to its occurrence will increase the frequency. The main focus is reinforcing positive behavior. The treatment we chose is aversion therapy. Why we chose this is because we believe aversion therapy can focus on the behavioral aspect of John's addiction and could promote John to seek help and change his habits with addiction. What is aversion therapy? Aversion therapy is a type of treatment that uses techniques such as classical conditioning to reduce and/or eliminate behavior promoting addiction. How we would implement this is John would need to attend sessions that are about an hour long. The timeline of treatment can vary depending on his reaction to the treatment. The treatment will gradually progress from assessing John's condition, participating in treatment sessions, and follow-ups with therapists after his treatment is finished.
Effective treatment programs typically incorporate many components, each directed to a particular aspect of the illness and its consequences. Substance use disorder treatment must help the individual stop using drugs, maintain a drug-free lifestyle, and achieve productive functioning in the family, at work, and society aspects. Patients typically require long-term and repeated episodes of care to achieve the ultimate goal of abstinence and recovery in their lives. Effective treatment attends to multiple needs of the individual, not just his or her drug abuse. Treatment must address the individual's substance use disorder and any associated medical, psychological, social, vocational, and legal problems. Behavioral therapies, including individual, family, or group counseling, are the most commonly used forms of treatment. Behavioral therapies, such as aversion therapy, vary in their focus and may involve addressing a motivation to change, providing incentives for abstinence, and building skills to resist drug abuse, and replacing them with activities including constructive and rewarding activities, as well as ones to improve problem-solving skills and facilitate interpersonal relationships. Participation in group therapy and other peer support programs during and following treatment can help maintain abstinence.
Okay, John, I'm going to attach an electric node to your hand. Now, I want you to try and take the given drug when I tell you to. Okay, now. Okay, here we go. Ow! How was that? It hurt. How are your cravings? Significantly less. Okay, so the therapist would first want to deal with the underlying issues affecting John's substance abuse disorder, which I believe had to do with John's father. After properly dealing with the underlying cause, we would then shift to an aversion therapy, which involves classical conditioning between a negative experience and the drug itself. Drugs have the expectancy of reducing tensions and lifting mood, so there is need for an even stronger pain stimuli to override the expectancy of the drug euphoria. In my example, I used electric shocks. However, the imagining of violence while taking heroin, in John's case, might work better since he experienced significant violence from his father in his childhood. These memories would no longer be a reason to use drugs in John's case, since he is better able to regulate his emotions due to preceding talk therapy.
Indicates that most individuals with substance use disorders need at least 3 months in treatment to significantly reduce or stop their drug use, and that best outcomes occur with longer durations of treatment. Most people who enter and remain in treatment stop using drugs, decrease their criminal activity, and improve their occupational, social, and psychological functioning. Treatment also helps individuals understand relapse triggers and how to plan for relapse. Recovery is a process, and the chronic nature of addiction means that some people relapse or return to drug use after an attempt to stop, which can be part of the process. Continuing care and aftercare can support recovery, particularly after formal treatment has ended. When a patient demonstrates significant progress in achieving treatment goals and other associated supports are in place, he or she may be ready to be discharged from treatment services. Things needed to be demonstrated are substantial progress in achieving individual treatment goals, sobriety with evidence that the individual knows how to avoid relapse and live a sober life, which can include things such as having a sponsor or regularly attending Alcoholics or Narcotic Anonymous meetings, stabilization or resolution of any serious medical or mental challenges with appropriate plans for continuing or re-entering treatment as needed, evidence of a well-developed support system.